So the first type of glaucoma that we are discussing, everybody, is primary open angle glaucoma. Open angle, okay. But why have I written the word primary? See, again, primary and secondary diseases. Primary, which do not have any other disease associated. So the glaucoma is occurring due to some inherent problems, inherent mechanisms as discussed, right? There is no other issue. It's not a lens-induced glaucoma. It's not due to some retinal condition. Primary open angle glaucoma in the yesteryears was also known as chronic simple glaucoma. This name is no more used, but still I'm mentioning it for you because of one word. This name told us that primary open angle glaucoma is a chronic disease. Yes? So it does not have any acute symptoms, acute signs. The patient will not come to you as an emergency patient. This is almost always an accidental, incidental finding. And also, if I think about it, grossly saying, chronic diseases like diabetes and hypertension are more common in which age group? Young adults or older adults? 20-year or 50-year? Yes. So I can learn from this point that because it is a chronic disease, it is more common in old age, greater than 50 years of age. It's not a hard and fast rule, but yes, it is more common in old age. Also remember, it is usually bilateral and symmetrical. Open angle glaucoma is usually bilateral and symmetrical. Then family history is strongly present. That means if my parents have it, I have a greater chance of having it. Because family history is present, I'm basically somewhere saying that some genes are involved. So what are the genes which are involved, which are mutated in the causation of hereditary primary open angle glaucoma? 3 genes, everybody. The first gene is optineurin gene. This question was asked in AIMS 2014. Second gene is MYOC, myocilin gene. And the third is WDR36. There are approximately 36 genes which have been postulated, but only 3 are confirmed to be associated with hereditary open angle glaucoma. Right, guys? Now, once we know this simple etiological associations, let's see what are the symptoms of open angle glaucoma. As soon as I say symptoms, and if I ask you to think about it, usually the first symptom that people say is, sir, blurring of vision, diminution of vision, loss of vision. I am saying wrong. Yes? Why wrong? You will understand. Then a lot of you may say, sir, pain in the eye, wrong. Then you may say, sir, there are redness, halos, vomiting. Wrong. This is usually the list that we are used to studying. Yes, but I have said everything wrong. Why, guys? That is why if you focus, I have said what are the symptoms of open angle glaucoma. There is a clear distinction, as already tried to explain to you everybody, between open angle and angle closure glaucoma. Pain in the eye, redness, vomiting, they are more indicative of an acute pathology rather than a chronic pathology. And thus we will see that all these symptoms that I have written and crossed are all symptoms of angle closure, but not of open angle. I will again repeat, there are 2 entirely different types of glaucoma. The pathogenesis of open angle glaucoma is in meshwork, of angle closure glaucoma is in iris. This is a chronic disease, that is an acute disease. The sign, symptom, treatment, everything is different. That is what we are trying to learn here so that we don't jumble our knowledge. We don't answer questions on glaucoma. We answer questions on open angle or angle closure. So what are the symptoms? If someone of you was saying headache, then you are absolutely correct. Headache is a symptom of open angle glaucoma. Okay, but again, you understand these are all non-characteristic symptoms. Headache can occur in thousands of other pathologies in the eye, neurological, everything. The second symptom is delayed dark adaptation. Delayed dark adaptation. Dark adaptation means the time you take when you come out from a bright sunlight into a dark room to be able to see the outline of objects. Yes or no? Doesn't it occur with everybody? If we come out from bright sunlight into a dark room for, let's say, 30-45 seconds, we are not able to see anything. Then we start seeing the outline of all the furnitures and everything. Yes? This is because in bright light, cones are functioning, in dark, rods have to function. Yes? So this transition, dark adaptation, takes normally 30 to 45 seconds. But in cases of open angle glaucoma, this gets delayed around, let's say, 1.5 minutes or 2 minutes. Then the third symptom is frequent changes of, if you are saying frequent changes of glasses, you are wrong. You are missing one word, of presbyopic glasses. Frequent changes of presbyopic glasses. I am not saying that the spectacles you are wearing, myopic spectacles for far vision, will change. No. Specifically, the spectacles which a patient is wearing after 40 years of age due to insufficiency of accommodation, presbyopia, the patient will say after every 6 months or a year, they keep on changing. Yes? So that is a characteristic symptom of open angle glaucoma. But again, they are non-specific, non-descript. Usually the patients do not complain of it. This is an accidental and incidental finding. These are the only 3 symptoms. All the other symptoms that we know will come in angle closure. Now, once we know the symptoms, let's move on to what are the signs. Number 1, IOP, intraocular pressure. Intraocular pressure can be raised, most important risk factor, in most cases raised, greater than 21 mm of Hg. But as we saw in the definition, it can even be normal. So how do we define glaucoma with a normal IOP? Greater than 5 mm Hg difference between both eyes. Let's take an example. Let's say my right eye has a pressure of 12 and my left eye has a pressure of 19. Both are within the normal range, yes or no? The normal range is 11 to 21. But still the difference between both the eyes is greater than 5, it is 7. When this is so, we say the eye with the higher pressure, even though it is within the normal limit of IOP, can have glaucoma. Okay, everybody? Then thirdly, greater than 8 mm Hg difference in diurnal variation is also indicative of a patient having glaucoma. Okay, everybody? So these are the 3 ways we measure IOP and we are able to think about glaucoma. Now, after we have measured the IOP, we will start to examine the optic disc. Optic disc signs. Remember the optic disc anatomy, everybody? Disc, cup, neuroretinal rim. You can say almost the diagnostic sign, the first finding that we see is loss of neuroretinal rim, which leads to vertical cupping. I have written them as 2 signs, but actually they are a single sign if you try to understand it. I am saying that due to glaucoma, the nerve fibers will be damaged. So if my optic disc, this was the neuroretinal rim, everybody. Neuroretinal rim consisted of nerve fibers. The nerve fibers are getting damaged. So my neuroretinal rim will be lost. Okay. When my neuroretinal rim gets lost, try to understand the central depression or the central cup, everybody, will appear larger. When my central cup will appear larger, everybody, I will say CD ratio becomes greater than 0.5 and I start calling it cupping. Are you able to understand this? The cup is becoming larger because the neuroretinal rim is getting lost. Both are the same sign if we say so. Yes, loss of neuroretinal rim initially affects inferotemporal neuroretinal rim. Initially it affects only the inferotemporal part of the neuroretinal rim, gets to be known as polar notching. Polar notch. A notch. And lastly, nasal NRR is affected. Okay, are we clear about this, everybody? There should be no confusion in this. Yes? Now, if we understand both these points together, let's see both these points in an image. Let's see the first photograph. Photograph A on the left of your screen. Everybody, if we are able to see, I am drawing the outline for you. This is my complete optic disc. In the center, a smaller, brighter yellow depression is visible. That is my optic cup. If I see carefully, I can say CD ratio is 0.3 or maximum 0.4. But if I see the second image, everybody, these are the boundaries of my optic disc. And now if you see, everybody, the optic cup has become very large. Why has the optic cup become large? Because of loss of neuroretinal rim. I can say the CD ratio must be around 0.8. Yes or no? Approximately it is around 0.8. That means it is a case of glaucoma. Are we clear about this, everybody? Yes? So the loss of neuroretinal rim makes the cup larger. It is easier to see a larger cup, and that is why that is becoming a sign vertical cupping. Okay? No confusion about this? Now, let's move on to the third sign. Third sign, laminar dot sign. Due to the large cup, now the fenestrations of sclera are visible as gray-white dots. Do you remember what was lamina cribrosa, everybody? An opening in the sclera, lamina cribrosa, an opening in the sclera, sieve-like, which allows all the nerve fibers to pass through. Now, because the optic cup has become larger and deeper, we are able to see that sieve or that lamina cribrosa. So it gets appeared as gray-white dots. Okay? Now, next sign, everybody. Splinter hemorrhages on optic disc surface. Splinter hemorrhages on optic disc surface. Next sign, everybody. Bayonetting sign. Bayonetting sign. Double angulation of blood vessel. Double angulation of blood vessel. Let's try to understand this. Bayonetting sign. Okay, everybody? Now, normally, this is how my optic disc and optic cup are. Let's say this is my optic disc. So this is my optic cup. Yes? My optic cup is slightly, you can say, sloping edges. So the blood vessels, the arteries which are coming in will come in like this and will bend. Okay? But in cases of glaucoma, what occurs is that the cup becomes large and deep with straight walls. So this is how my cup becomes. Again, this is my optic disc margin. This is my optic cup. So now the blood vessel will have to make a bend to go along the floor of, to go along the wall, straight wall of the optic cup, and then it will make a bend again at the floor of the optic cup to go out. Okay? So due to a large, deep cup with straight walls, now my blood vessel will be seen to have two angles. First angle, second angle. Rather than a normal straight sloping vessel, I have a double angulated blood vessel. And this angulated vessel is bayonetting sign. Let's see the image, everybody. Let's see this image. Now, once you've been able to understand it, I hope you are able to see it. See? The cup is large. Everybody, I hope you can make out the cup here. The cup is large. This is my optic disc. Yes. So the blood vessel is coming. Blood vessel is coming, forming one angle, then forming another angle. Yes, I hope you can see everybody. Yes. So let's just see it again. I'll just clear it for you. Double angulation of a blood vessel, very clearly visible in the image on the screen. Bayoneting sign. Done? No. Next sign, everybody. F. Retinal nerve fiber layer wedge shaped defects. Retinal nerve fiber layer wedge shaped defects. At last, the nerve fibers of the retina are constituting the optic nerve. So as the earliest sign you can say, everybody, of a glaucoma, this is what it is seen, everybody. Okay. So this is for early detection of glaucoma. Then lastly, peripapillary atrophy. Peripapillary atrophy. Very simple to understand, everybody. Peripapillary atrophy. Peri means around. Papilla is again and again stated throughout neuro-ophthalmology. Papilla means optic disc. So around the optic disc, you will see zones of atrophy. Everybody, I'll draw a diagram for you. If this is my optic disc, optic cup, these are my blood vessels. Okay. Around the optic disc, you will see a crescent shape or a moon shaped zone of atrophy, which is divided into two zones. The inner zone appears whitish in color. This is known as beta zone. Whereas the outer zone is black in color. This is known as alpha zone. Alpha zone is specific for glaucoma. Beta zone also seen in myopia. Okay. So two zones of atrophy, everybody, alpha zone and a beta zone. Done. Peripapillary atrophy. Please remember, alpha zone is what is specific for glaucoma. Done. Now, that's all about my optic disc signs. The classic sign, diagnostic sign being vertical cupping due to loss of neuroretinal rim. Then all the other signs as explained to you. After we have done the optic disc signs, let's move on to the visual field changes. Visual field changes or visual field effects examined through perimetry. Now, the first question that the examiner will ask you is, what is the earliest visual field defect in case of glaucoma? Earliest visual field defect in case of a glaucoma. If you are answering paracentral scotoma through your knowledge, then you are absolutely wrong. The earliest visual field defect is called as isopter contraction. Isopter contraction. Okay, everybody? Now, isopter contraction is basically, if you remember, this is what we had drawn as a visual field. Yes? So, a 2D representation of our visual field is called as an isopter. So, peripherally, throughout, everybody, there is constriction of visual field. So, we say the isopter, which was normally this large, the recording 2D diagram, has become slightly smaller. After isopter contraction occurs, bearing of blind spot. A non-specific visual field defect does not hold any clinical significance at all. After bearing of blind spot occurs paracentral scotoma. Paracentral scotoma. Paracentral does not affect the center, around the center. Okay. So if I draw a simple diagram for you, 30 degree, 20 degree, 10 degree. If you remember, perimetry usually examines the central 30 degree only. This is my fovea. This is my blind spot. Yes. So around the center, everybody. there will be another scotoma, and this is what I will call as paracentral scotoma. Okay? Now, the paracentral scotoma will grow into something we call as Siedel's scotoma. Siedel's scotoma is sickle shaped. Easy to remember, guys. Siedel sickle. Okay? Now, what is the logical extension of paracentral scotoma? Paracentral scotoma will say there is a naturally occurring blind spot. Yes? One scotoma which has occurred due to glaucoma, one blind spot which is normally present in everybody. The two will link together. When the two will link together, it will be something like this. Yes? Try to imagine a continuation of the paracentral scotoma. What kind of shape has it assumed, everybody? A sickle shape, and this is called as Siedel's scotoma. Then the Siedel's scotoma progresses to what we call as arcuate scotoma, also called as Bjerrum scotoma. This is not Jerem, guys. This is pronounced as Bjerrum. Bjerrum scotoma. Okay? Now, Bjerrum scotoma appears like this. This whole area, everybody. This is your arcuate scotoma or Bjerrum scotoma. Okay, the sickle shape has extended towards the nasal side and then affected a large area. Now the question comes, why is this known as an arcuate scotoma or Bjerrum scotoma? For that, let's see this image, everybody. This is the orientation of nerve fiber bundles in the retina. From the optic disc to the macula, everybody. The nerve fibers which go are called as PMB, papillo optic disc macular bundle, PMB, papillomacular bundle. Then the fibers, everybody, which arch from the optic disc above the macula and then go and meet the horizontal raphe. These fibers are called as arcuate fibers. Superior arcuate fibers and inferior arcuate fibers. If you carefully see the Bjerrum scotoma or the arcuate scotoma we have drawn it like this, affecting the optic disc, then arching above the macula and like this, everybody. Yes? Because this scotoma is affecting the arcuate fibers, that is why we are calling it arcuate scotoma. This part of visual field is called as Bjerrum area, and that is why it is called as Bjerrum scotoma. Okay, everybody, am I clear? Arcuate nerve fibers, Bjerrum area, arcuate scotoma, Bjerrum scotoma. Now, let's come back here. Once arcuate scotoma has occurred, you will carefully see that the horizontal line is being respected. Yes, superior arcuate fibers. Now what will occur? The inferior arcuate fibers get affected, and thus it will become a double arcuate, or what I can call as ring scotoma. Now, I'll just draw it in this image only, everybody. Inferior arcuate fibers also getting affected. So now if we carefully see, everybody, the central vision is being still left out, papillomacular bundle, but the superior and inferior arcuate fibers both are going, so it's becoming a ring scotoma. Okay? Now, after ring scotoma, everybody, occur step defects. Step defects. Okay, what are step defects? Let's try to understand this from the image that we have drawn above. Again, if we carefully see, the superior arcuate is this and the inferior arcuate is this. Yes? There is unequal contraction. Can I say? Superiorly, the contraction of the visual field of the scotoma is smaller than the inferior scotoma, which is leading to the formation of a step or a CD. Yes? And this is called as a step defect. So step defects can either be central step defects or Ronnie's peripheral step defects. Either they can be seen centrally or they can be seen peripherally. But why do they occur? Due to unequal contraction or loss of nerve fibers in upper and lower parts. Yes or no? The upper part nerve fibers are being lost at a slower pace in this example than the inferior nerve fibers. And that is why a step is being formed. Done, everybody? After step defects, gets lost the visual field which we were so dearly trying to preserve. Loss of central visual field. So if I now ask you, everybody, as a disease, glaucoma is affecting mainly which visual field? Central or peripheral? Peripheral. And that is why usually the patients do not present to us with loss of vision. Again, as stated, we use normally our central visual field. Peripheral visual field we actually don't use. That is just forming the periphery, giving us a complete vision. So it is very difficult to understand a peripheral loss of field in the early cases. But if your central vision is lost, you cannot see anything. You cannot carry out your day-to-day activities. So you will present promptly. In glaucoma, that is why the presentation is never with loss of vision. Done? Loss of central vision occurs after a long chain of visual field defects. So now if I ask you which is the last part of visual field to be lost in glaucoma, can you say central, everybody? Yes or no? Yes? No, guys, no. Even after central visual field is lost, there is a very small area in the temporal side that remains. Loss of temporal vision. And that is why we say temporal vision is the last affected or the most resistant, whichever way you want to say. Okay? Even after the central vision is lost, a very small area on the temporal side is left, can be remembered by a simple fundamental that normal visual field is maximum temporally. Because it is maximum temporally, temporal will be the last to be lost. That's just a simple trick to remember it, everybody. Okay? So this is our complete flow of visual field changes starting from isopter contraction, earliest, to the last affected being the temporal part of vision. One more point to understand and remember in this flow of visual field. If we carefully see paracentral scotoma, sidal scotoma, arcuate scotoma and double arcuate scotoma. All these scotomas are actually occurring in the part where arcuate fibers are present. Even the paracentral scotoma is affecting the arcuate fibers. Sidal scotoma, everything. So we say all these occur in which part of the visual field? Bierum's area of visual field. So all the four defects, paracentral, sidal, arcuate and double arcuate, they are actually affecting Bierum's area only, partially or fully. Okay, everybody? I hope we understand this. There should be no confusion about this. That's all about the visual field changes in a case of open angle glaucoma. If you understand, that's all about the signs, IOP, optic disc and visual field. Does not have any acute symptoms or acute signs which will present in the anterior segment. On gonioscopy, as we have already seen through either Van Herrick's oblique test or the gonioscopy, the angle will be open as discussed previously. That leaves us with what, everybody, now? Sign, symptom, etiology done. So we move on to the treatment of open angle glaucoma. Okay? Now the treatment, is it medical or surgical? Do we give anti-glaucoma drugs? Yes, we give. Can we do surgery? Yes. So medical treatment obviously will be first instituted. If uncontrolled, we have to go on to surgical treatment. So let's first discuss the medical treatment. Again, understand, everybody, medical treatment is being given to glaucoma. The problem is in the anterior segment of the eye, anterior chamber and posterior chamber. So which route of drug administration should I use? For any pathology in the anterior segment, we always try and use first of all the topical medications. Similarly, as explained to you previously also, for any pathology in the posterior segment, we will try and use intravitreal. So that is a common sense you can apply to every disease in ophthalmology, apart from certain specific indications of other routes. Okay. So all the medications that we institute will be given as topical eye drops. What are the groups of medications? The first important group of medication is prostaglandin F2 alpha analogs. Prostaglandin F2 alpha analogs. What are the drugs in this, everybody? Latanoprost, bimatoprost. Okay. And we can continue on the list. Travoprost, unoprost, tafluprost. These are the drug of choice. There should be no confusion. If you still believe timolol is a drug of choice, that's a very old knowledge. The drug of choice are prostaglandin F2 alpha analogs, latanoprost or bimatoprost or the other prosts here. Okay, everybody? Now, important point about these drugs. What is the mechanism of action? Mechanism of action of any drug in glaucoma can be three. Think about the pathogenesis and reverse it. In pathogenesis of glaucoma, we said there can be either increased secretion. So as a mechanism, we can either have decreased secretion. There can be blockage of outflow. So as a mechanism of a drug, there should be increased trabecular outflow or increased uveoscleral outflow. Can I say this? So there can be any of the three mechanisms, either decreased secretion or increased trabecular outflow or uveoscleral increased outflow. Which of the following is the mechanism of action for prostaglandin F2 alpha analogs? The answer is increased uveoscleral outflow. Okay, everybody? Now, please remember one of the reasons why latanoprost became drug of choice is because of its OD dosing, once daily. Whenever there is once daily dosing, the compliance of the patient is better. Yes, timolol used to be the drug of choice. Apart from the fact that latanoprost is giving us good results for IOP control, the compliance is increased because timolol was BD, this is OD dosing. Okay. Now, if OD dosing, then what is the patient going to ask you? Sir, when do we put it? Morning, evening, with milk, without milk, with water? You understand what I'm saying? So please advise the patient to put it at 9 p.m. Okay. OD dosing done at 9 p.m. 9 p.m. is one of the most famous brands for latanoprost eye drops also. Now, what are the ocular side effects? Very important question. Anti-glaucoma drugs are usually used for a long time. So usually patients will end up with some of the side effects. This is an examiner's favorite. A lot of questions get asked on this ocular side effects of anti-glaucoma drugs. So please do remember them carefully if you don't through your pharmacology. The first important ocular side effect that I would like to say is hyperpigmentation of iris. Hyperpigmentation of iris. If I am putting latanoprost in my right eye, my right iris will become hyperpigmented. If both, yes. The second important side effect is something which is of quite a lot of use to females, I will say, getting ready for marriages and parties and everything. Females are concerned about their eyelashes curving outside, being dense and everything, yes. If you are concerned, use this side effect to your benefit. Hypertrichosis. Hypertrichosis. There is growth of eyelashes. Okay. Even though this is a side effect, actually, bimatoprost is FDA approved for treatment of hypotrichosis. You can use it. It's a very simple treatment. Yes. Number 3. The third important side effect is this causes inflammation in the eye, uveitis. Fourth, cystoid macular edema. Can cause macular edema, can lead to loss of central vision. Very important side effect. Fifth, reactivation of herpetic keratitis. When I write this, I hope I can emphasize on the point of history taking. That is why in every case, history taking becomes important. As an ophthalmologist, if I see a case of glaucoma and institute latanoprost without taking any history or ruling out any previous episode of herpetic keratitis, this is the risk we run. Okay? So history taking is an important aspect of any clinical field. I hope you do learn it to the best of your abilities to be able to practice in a much better, much more efficient way, guys. Okay? These are the important side effects of prostaglandin F2 alpha analogs. That's our first group. Now, second group of drugs, everybody, that we can use, as I was already mentioning, will be your beta blockers. Okay? Beta blockers. Now, which beta blocker is commonly used? All of us know timolol. Timolol. The dosing, as I have already stated, will be BD, 2 times a day. Also, commonly or rather uncommonly, I can say, used is bitoxolol. Okay? What is the mechanism of action for both of these? Beta blockers, everybody. Beta blockers will block the beta 2 receptors on the ciliary processes and will thus decrease the aqueous secretion by inhibiting the CAMP released. Okay, everybody? So, decreased aqueous secretion. Now, what are the ocular side effects? So the ocular side effects are, number 1, blepharoconjunctivitis. Blepharoconjunctivitis. I hope you understand the meaning of this word yourself. It is made up of 3 words. Itis. Itis means inflammation. Inflammation of conjunctiva and blephar. What is blephar? Blephar is eyelid margin. Eyelid margin means the point where your eyelashes come out from. So there is inflammation of conjunctiva and eyelid margin. I hope there is no confusion in this. Yes? Then, the second important side effect is NLD blockage. Nasolacrimal duct blockage. Nasolacrimal duct. Yes? Third important side effect is corneal anesthesia. This has already been stated as a cause of corneal anesthesia in the lecture on basic anatomy, where we had given the mnemonic HDLACTS. HDL acts, T for topical timolol eye drops. Okay. Then the fourth important side effect, which is specific for bitoxolol use only. Bitoxolol can cause aphakic cystoid macular edema. Basically, cystoid macular edema if the person is aphakic. So you should not use bitoxolol in aphakia. That's all, as simple as that. Okay. I hope apart from the ocular side effects, we know the contraindications of beta blockers. Systemic contraindications A, B, C, D. It's important to remember this. A for everybody, arrhythmia. I hope you know this in a better way through your pharmacology. B for bronchospasm. It can exacerbate asthma. C for CHF, congestive heart failure, and D for diabetes. So in this 4 group of patients, you should avoid using beta blocker at all costs. Okay, everybody? A, B, C, D. Simple way to remember contraindicated beta blockers. Okay. Now, third group of drug, everybody. The third group of drug that we can use is the opposite of beta blocker. That is alpha agonists. Alpha agonists. As part of alpha agonists, we have 2 drugs which we can use. Apraclonidine and brimonidine. I am writing them separately because even though they are the same group of drug, their mechanisms slightly differ. The main mechanism of both drugs is to decrease the aqueous secretion. But apraclonidine also increases the trabecular outflow. So that's an additive action that apraclonidine has. It increases the trabecular outflow. Similarly, the side effect profile of both these drugs differ from each other. Apraclonidine very commonly causes follicular conjunctivitis. Okay, follicular conjunctivitis. Secondly, it can lead to dilatation of the pupil, mydriasis. That is why, if you remember neuro-ophthalmology, anisocoria, apraclonidine 1% test is used for Horner's syndrome, to dilate the pupil in Horner's syndrome. Yes, I hope you do remember it. And thirdly, the third important side effect is eyelid retraction. Eyelid retraction. Opposite of ptosis, again everybody, retraction means the eyelid will be upward. Okay, upper eyelid goes up. Eyelid retraction. These are the three important ocular side effects of apraclonidine. Also remember, for apraclonidine, this is the drug of choice for IOP elevation post laser treatment. Whenever you do any laser procedure in the eye, your IOP is bound to get elevated. Laser is a beam of energy. Some of the energy is lost and transferred to aqueous and everything. So the IOP gets increased. So for all post-laser cases, when you know the IOP is going to increase, you have to prescribe apraclonidine. Okay, everybody? Please remember this. Now, let's move on to the side effects of brimonidine. Actually, they are not side effects. You can say actually they are contraindications. Brimonidine can lead to drowsiness. I hope you are not feeling drowsy right now. If you are feeling drowsy right now, if you are feeling drowsy in your lectures, then you will ultimately land up in the state of depression. And now I'm not talking about the ocular depression, the psychiatric depression. When you go and see the paper, you will start to hyperventilate because you will start to experience hypnea or apnea. Okay? And you may experience bradycardia. So if you don't study, you can experience all the side effects of brimonidine, everybody. Basically, what I'm trying to say, if you try to understand that brimonidine is suppressing all the neural functions, that means brimonidine is a CNS suppressant. Because brimonidine is a CNS suppressant, it is contraindicated in children. Please remember, it is contraindicated in children. Okay? So recently a question was asked in NEET 2 years back. A child has apnea on anti-glaucoma treatment. Okay? So 2 keys were given. If you didn't remember apnea, you remember child. In children, only one drug has side effects, brimonidine. Okay, so both the clues. If you remembered apnea, well and good, everybody. If you didn't, then also you could have answered this question. Okay, done? That's your third group of drugs, everybody. Alpha A agonists, apraclonidine and brimonidine. Moving on to the fourth group of drugs, everybody. I hope you remember one important group of drugs. Carbonic anhydrase inhibitors. Carbonic anhydrase inhibitor. Carbonic anhydrase inhibitors are acetazolamide, brinzolamide, dorzolamide, and lots more, guys. Restricting myself to these 3. Please remember the very important point about acetazolamide. First of all, acetazolamide is not given topically. We can't give it topically, guys. Okay? Acetazolamide in India is not available in topical formulation. It is only available as an oral formulation, everybody. So, all the drugs anti-glaucoma are given topically except acetazolamide. Now, what is the mechanism of action of all these drugs? Should be very clear. Because of being diuretics, decreased aqueous secretion. Okay? Decreased aqueous secretion. Please remember, they are contraindicated in sulfa allergy. Deviating a little bit from topic, dorzolamide is used in children. So if you have a childhood glaucoma, if you have a case of a 5-year-old, 4-year-old having glaucoma, and if you're not doing any surgical procedure, then dorzolamide is a safe drug to give in children. Just remember this as an extra point, guys. Okay? No confusion here. Done? So these are the 4 group of drugs that we as students normally know of, should know of. I have tried to teach you with the ophthalmology mindset. You should know much more through your pharmacology knowledge. But apart from these 4 group of drugs, do we have any other group of drug? Yes, we do. New group of drugs, if I call it, there are 2 new group of drugs. Number 5, E. Nitric oxide donating prostaglandin analogs. Nitric oxide donating prostaglandin analogs. The name of the drug is latanoprostene bunod. Latanoprostene bunod. As you can see from the name, it is a latanoprost molecule only. Yes, latanoprostene bunod, when administered, gets broken into obviously latanoprost, also butadienol. Butadienol is an unstable compound. This donates nitric oxide to become stable. Now, we may know that nitric oxide relaxes the muscles. So, what will occur, everybody? Relaxes trabecular meshwork. Trabecular mesh is basically made up of muscle. By relaxing the trabecular meshwork, it is increasing the trabecular outflow, and latanoprost as such will increase the uveoscleral outflow. So I hope you understand that this is probably a better drug than latanoprost because it has the action of latanoprost plus an additional effect in increasing the main outflow, that is the trabecular outflow. Okay, everybody? Now, the last group of drug, another new group of drug, relatively new group of drug, is Rho kinase inhibitors. This is not a new group of drug in the form of the group, but in the form of the use in glaucoma it is new. The compound that we use is nitarsudil. Nitarsudil, that's the compound that is used. What is the mechanism of action of nitarsudil, everybody? It has dual mechanism of action. Number 1, it decreases the aqueous production by inhibiting norepinephrine transport. Secondly, it increases the trabecular outflow by promoting actin myosin contraction. By promoting actin myosin contraction, I hope you understand how muscles contract. Coupling of actin and myosin occurs, contraction. So my trabecular meshwork is contracting, contraction, relaxation. This kind of a movement will lead to pumping action. Pumping will be able to increase the trabecular outflow. Okay. Now, what are the ocular side effects? Nothing major, but it can lead to a very important side effect which is called as cornea verticillata. Spindle-shaped deposits in the cornea caused by a lot of other drugs also. Cornea verticillata. Okay, everybody? Done? That's all about our medical treatment. 4 main groups. The drug of choice being latanoprost. Then the mainstay, first line treatment, but not the drug of choice, timolol, beta blockers, then alpha agonist, carbonic anhydrase, and then 2 new drugs, latanoprostene bunod, which is a nitric oxide donating prostaglandin analog, and Rho kinase inhibitors. These are the drugs that we normally use. We start with one drug, then we move on to dual therapy, then multi-therapy. If all the therapies do not get controlled, yes, then we have to move on to our second treatment option, everybody. And our second treatment option obviously is surgical. If we understand the mechanism of open-angle glaucoma, it was due to blockage of trabecular meshwork. Yes, trabecular meshwork is the site of pathology. So whatever surgery I am doing must be done at the trabecular meshwork, must be done to open the trabecular meshwork. Yes. So surgery name should be something called trabeculo. That's the first thing we understand through common sense. Secondly, everybody, which surgery would you prefer? A laser surgery or an open surgery? Anywhere in the body, guys, closed or open? Closed? Yes. So let's first discuss the name of the laser surgery. We are using a laser to repair the trabecular meshwork, laser trabeculoplasty. Okay. This laser trabeculoplasty can actually be of two types, ALT or SLT. ALT means we are using which laser, everybody? Argon laser. Argon laser or argon laser, 510 nanometer. And in SLT, the full form is selective laser trabeculoplasty. Selective laser trabeculoplasty it is called as because selectively laser is applied to only the pigmented portion of trabecular meshwork. It is applied only to the pigmented trabecular meshwork. Which laser is used? Still the question remains. So the laser used is frequency doubled ND-YAG laser. Frequency doubled ND-YAG laser. Now everybody, we have already read about ND-YAG laser. That ND-YAG laser acts by photodisruption, by breaking the tissue. In the chapter lens, ND-YAG laser capsulotomy. Are we breaking the trabecular meshwork here? No. That is where physics comes in, everybody. We are saying frequency doubled. If you remember physics, physics used to say frequency is inversely proportional to wavelength. If I double the frequency, the wavelength will become half. So the wavelength of frequency doubled ND-YAG is 532 nanometer. If you see it approaches close to argon laser, the mechanism of both lasers, everybody, argon laser as well as double frequency ND-YAG laser, both of these work by photocoagulation. Both of these work by photocoagulation. We are not breaking the trabecular meshwork. We are coagulating, inducing fibrosis in one part of the meshwork. If I induce fibrosis in one part, that will contract, that will stretch all the other meshwork. When it stretches all the other meshwork, the holes will open. Can you imagine? Can you understand this? One part will contract, the other part will open up. First of all, my mesh was like this. Everything was blocked. Now I apply laser burn on this part. So what will occur? This is what will occur, everybody. All the other holes will become larger because this area is contracting and pulling all the other mesh. You understand this, everybody? Yes? So, if you understand the mechanism, let's please remember selective laser trabeculoplasty, SLT, is the treatment of choice for prophylaxis in other eye. Why do we say prophylaxis in other eye? Because we have already noted that open angle glaucoma is usually bilateral. We know it has presented in one eye, it will present maybe a little while later in the other eye. So prophylactically we are doing selective laser trabeculoplasty in the other eye to prevent it. For treatment in the eye which has occurred, and for prevention, the treatment of choice in the other eye. Now, apart from laser trabeculoplasty, we can do some open surgeries also. So what are the open surgeries we can do? Again, please remember the problem is in trabecular meshwork. So the name of the surgery now becomes trabeculectomy. Culec means to cut. Culec basically means to cut. Okay, everybody? So by cutting of the trabecular meshwork, a fistula is created between the anterior chamber and subtenon's space. So through this fistula, everybody, now the aqueous will start to drain below the tenon's capsule. From there, it will be absorbed into the lymphatic drainage. Okay. Now, the most common cause of failure of trabeculectomy is fibrosis of this fistula. The opening can get fibrosed if not made properly. That is why we use antimetabolites like mitomycin or 5-fluorouracil, yes, to avoid this fibrosis so that the fistula does not close. If the fistula closes, then my trabeculectomy will become useless. Okay, everybody, done? Then, apart from trabeculectomy, we have some certain surgeries which are called as non-penetrating surgeries. I'll give you examples of non-penetrating surgeries names, everybody. Deep sclerectomy, viscocanalostomy. Okay, in these surgeries, we are not penetrating the trabecular meshwork. We are not touching the trabecular meshwork. We are in one way bypassing the trabecular meshwork. Straight away into the sclera or straight away into the Schlemm's canal. Sclerectomy, canalostomy. Okay, everybody? So if you think about your blockage of the coronary arteries, you can either do angioplasty, you can break through the block, or you can do a bypass. Similarly, we are doing trabeculectomy, breaking through, or we are doing a bypass. Okay, everybody? They have less chances of post-operative complications. Next, everybody. Next, we can use a newer technique which is called as MIGS. Micro-incision. Micro-incision glaucoma surgery. This is a new advent in the surgical treatment of glaucoma, everybody. They are becoming popular day by day. There can be 3 types of procedures. As you can see, number 1, canal-based procedures. Okay? Canal-based means we are somewhere manipulating the Schlemm's canal, increasing the trabecular outflow. In these, we implant some devices. What is the device we implant? Known as eye stent, made up of titanium. Please remember this much at least. The rest you can read. Secondly, everybody, suprachoroidal procedures. Suprachoroidal space, that means it will increase the uveo-scleral outflow. The name of the implant is called as CyPass, and it is made up of polyimide. Okay, everybody? And then the third way that MIGS can be done is subconjunctival procedures. They also increase the outflow into the subtenon space, just like trabeculectomy. Okay, the device used is Zen gel stent, XEN gel stent, and because it is gel, it is made up of gelatin. Okay, everybody, just remember, micro incision surgeries, they're getting more popular because incision is smaller, so the healing time is lesser, the chances of infection after the surgery are lesser. Just remember these names and certain information listed here. Now, the last procedure that we can do, everybody, is known as glaucoma drainage devices, okay, also known as Seton's surgery. Seton surgery is a very old name actually. This is no more used. We say now we are implanting a drainage device. Somewhat similar to MIGS, but the drainage devices are much larger. So that is not a micro incision surgery. Glaucoma drainage devices or Seton surgery is done in refractory uncontrolled glaucoma or in glaucoma with aniridia. Glaucoma with aniridia. Okay. In this, what is done basically? An implant is placed. Let's take the example of this image, everybody. This is called as the Ahmad glaucoma valve. This is known as the Ahmad glaucoma valve. This silicone tube, everybody, is placed inside the anterior chamber. This plate is placed below the Tenon's capsule. Now everything is blocked, no medicine, no surgery has worked. So this is an artificial implant, an artificial tube, which is drawing the fluid from the anterior chamber below the subtenon space. Similarly, you can see these two images. These are not sperms, everybody. These are not contraceptive devices, everybody. This is known as Bar-Welt implant. This is known as Moltena device. And this, as is written here, is known as Express Mini Shunt. This is made up of stainless steel. This question somehow was asked in AIMS again in the year 2014. Express Mini Glaucoma Shunt is made up of which material? The answer was stainless steel. Okay, everybody, done? So that's our surgical treatment. If you understand, the surgery is aimed around increasing the outflow by either laser treatment of the trabecular meshwork or breaking the trabecular meshwork or bypassing the trabecular meshwork, right? We have to increase the outflow because the main problem is blockage of outflow because of blockage of trabecular meshwork. When we start reading angle closure glaucoma, you will notice all this is different. The treatment basics are different. The disease is acute, so there will be acute signs and acute symptoms. And the mechanism, as we already know, is entirely different. The problem in angle closure glaucoma does not lie in trabecular meshwork like open angle glaucoma. Rather, it lies in the iris. Okay, everybody? Primary angle closure glaucoma now. After having done open angle glaucoma, let's discuss angle closure. Just like open angle closure also has another name. Acute congestive glaucoma. This name is actually still in use. A lot of your professors and everything would be using this name. But what is this name telling us? The word acute. Differentiating it from open angle glaucoma in the fact that open angle glaucoma was a chronic disease, but this is usually an acute presentation. And apart from the fact that we understand that it will be an acute presentation, it is more common to present in young adults around 20 to 40 years of age. More common, guys. Okay? Now, apart from this basic fundamental that we understand of the names, we understand there is congestion, congestive because the angle is getting closed. But how is the angle getting closed? That's what we want to understand. So let's understand the mechanism of angle closure glaucoma. Now, let's see this chart, everybody. Let's see the first step, relative pupillary block. Due to some risk factors which I will mention, the pupillary margin as seen in the image has an apposition. Apposition means it is touching. Oppose means to touch, to be near each other. Is in apposition to the anterior surface of lens. When this occurs, everybody, when this occurs, what will be the result due to this? All the aqueous that gets secreted in the posterior chamber, this area, will not be able to flow into the anterior chamber. Yes? So as you can see, apposition of pupillary margin against the lens surface, aqueous cannot flow from PC to AC. When the aqueous cannot flow from posterior chamber to anterior chamber, it is collecting in the posterior chamber, and that collection is pushing the iris forward. Pushing mechanism, everybody, you understand this? When the iris is getting pushed forward, because iris is a muscle, iris will bow down, iris झुक जाएगा आगे की तरफ. Anterior iris bowing, known as iris Bombay. Okay, everybody? So what is iris Bombay? If I ask you, iris Bombay is a convex iris. Can I say this? Instead of a flat iris, now the iris has become convex. वो आगे झुक गया है. Am I clear to everybody? I'll show you another photograph. See this image, everybody. Can you see a convex ballooned iris, everybody? Yes? The iris doesn't seem flat at all. This is a case of iris Bombay. I hope this photograph is very absolutely clear to all of you. Yes? Now, iris Bombay has formed, but as can be seen in image B, the iris and the cornea are still not touching each other. Whatever aqueous is there can still outflow. But due to the continued pushing, everybody, what will occur? Image C, the iris will start to touch the cornea. This is known as iridotrabeculocorneal contact, ITC. Iris and cornea touch each other. In between there was trabecular meshwork. Okay? Now, iridotrabeculocorneal contact has occurred. Contact means touch. If you do not remove things which are touching each other, what forms between them? Adhesion. चिपक जाएंगे. Yes? So now adhesions will form. When adhesions form, we call it synechia. Peripheral anterior synechia. Let's understand this name. Synechia means adhesion. Peripheral, because if you see, the central part of the iris is not forming the synechia with cornea. Which part of the iris is forming the synechia, everybody? Peripheral part. Where is the iris going, everybody? Anteriorly or posteriorly? Anteriorly. So we call it peripheral anterior synechia. Am I clear to everybody? Due to continued iris pushing anteriorly, iris comes in adhesion with cornea and trabecular meshwork. Now when synechia have formed, then I can say completely my angle has closed, and due to that what will occur? Angle closure. So I call it PACG, primary angle closure glaucoma. No worries, I hope. When I see a case of primary angle closure glaucoma, I see that the anterior chamber in the center is absolutely normal, but in the periphery, everybody, anterior chamber is very shallow. So central deep anterior chamber, peripheral shallow anterior chamber. The problem is in the periphery, everybody. If you look at my hands, this is my normal iris. In this case, the pupillary margin is going back on the lens surface, but the periphery is coming up. So this is like this. Instead of normal, I am like this. Okay, everybody? The periphery will touch the cornea. Periphery. Okay, everybody? This is what my angle closure looks like. I hope there is no confusion in this. Now, once we know the mechanism, everybody, let's know the risk factors. I said due to some risk factors, there is apposition. So what are the risk factors? Number one, the most important risk factor is hypermetropia. People who have hypermetropia, because hypermetropia has small axial length. The eye overall becomes smaller in size in hypermetropia. So all the structures come near each other. When all the structures are nearer to each other, it is easier to oppose. Number two, small cornea. Diameter decreased. Okay. Number three, if due to any other cause there is shallow anterior chamber. Number four, more common in females. And number five, plateau iris. A specific configuration of iris which is known as plateau iris. When there is plateau iris, it is anteriorly located. Okay. So that's an anatomical malformation, you can say. All these risk factors can be precipitated by dim light. All these factors can be precipitated by dim light. That is why patient is asked not to visit cinema halls. It is almost a retrospective finding, you can say, that in all patients who present to us with an acute episode of angle closure glaucoma, the pupil is found to be slightly dilated, and thus it has been postulated that mid dilatation or dilatation of pupil in dim light is a precipitating factor. If you go to a cinema hall, it is absolutely pitch dark, your pupil will dilate instantaneously and you will get an attack of angle closure glaucoma if you are predisposed or if you are already a case. For the similar reason, in every case of angle closure glaucoma, we say atropine is contraindicated. Atropine is contraindicated because atropine will dilate the pupil. We do not want the pupil to dilate if you are a case of angle closure glaucoma. As simple as that. Now, once you have been able to diagnose it as a case of angle closure, let's see the classification system. The classification that was followed previously in the yesteryears, subacute, acute, chronic, that is no more followed. Now we say, everybody, that there is something called as PACS, primary angle closure suspect. Primary angle closure suspect, somebody we are suspicious about. How do we define a primary angle closure suspect? In such a case, there will be normal IOP, normal optic disc, but there will be apposition in greater than equal to 3 quadrants. Basically, iridotrabeculocorneal contact. Okay? Contact is there. The angle is about to close, so you are calling it a suspect. Then comes the second stage, PAC. We are saying that there is primary angle closure, that the angle has closed. When will you say this again? There will be increased IOP now, but the optic disc will remain normal. And what would have developed instead of the iridotrabeculocorneal contact? Now would have developed, everybody, peripheral anterior synechiae. Okay? So the touch has changed to adhesion. You understand the mechanism, you understand this, that there was touch, now touch has changed to adhesion. So peripheral anterior synechiae have formed. But we are still not calling it glaucoma because the optic disc has remained normal. If you carefully see, the optic disc was normal. Unless there are optic disc changes, I cannot call the stage glaucoma. So now the next stage is PACG. In PACG, what will occur? Optic disc and visual field changes. So only when optic disc and visual field changes are seen, then you term it as glaucoma. Otherwise, it will be a case of PACS or PAC, not PACG. And that's the system of classification now for any angle closure person. Okay, everybody? Done? Now, what are the symptoms of angle closure glaucoma, everybody? So the symptoms of angle closure glaucoma are what we had stated previously. Number 1, headache. Number 2, there will be some loss, or I can say blurring of vision. Number 3, there will be pain in eye, severe pain. Number 4, the patient will experience nausea or vomiting. Number 5, due to the acute condition, there will be redness. And number 6, the patient will see halos around light. These are the 6 symptoms of angle closure glaucoma. As you can see carefully, all the things that we had written in open angle glaucoma, we have written here as being acute symptoms. Why do these symptoms occur? We will understand after some time when we discuss the science. Along with the science, I'll explain you the symptoms. Here, I want you to focus on the 6th symptom, halos around light. Halos around light is not a specific symptom of angle closure glaucoma. Okay? Halos around light can be seen in a mucopurulent conjunctivitis. Mucopurulent means discharge. Why are they seen? Due to discharge. Okay? Now, for this, what do? You wash the eye. You wash the eye, halos will disappear. It was due to some discharge lying on the corneal surface. You wash the eye, discharge goes, halos go. The second cause is cataract. And the third cause is what we are discussing here, everybody, angle closure glaucoma. To differentiate between cataract and angle closure glaucoma, everybody, we use this instrument. What is this instrument called as? This instrument is called as stenopeic slit. Stenopeic slit. With this instrument, we do Fincham's test. We do Fincham's test. Okay? We keep this stenopeic slit in front of our eye. We rotate it. On rotation, if the patient says that the halos appear broken, then the diagnosis is cataract. But even after rotating it, keeping it in front of the eye, the patient says the halos are intact, then the diagnosis is glaucoma. So on Fincham's test, halos appear broken. Broken means like this. Let's say these were the halos. Okay. So now the patient will be able to see them like this. Okay, with some breaks. But if the halos appear intact, intact means like this only. Here the answer is cataract. The other place the answer is angle closure glaucoma. So Fincham's test is used to differentiate between cataract and glaucoma. If I ask you everybody, Fincham's test is used to diagnose. Fincham's test is used to diagnose glaucoma or cataract or both. Again, I hope you remember that a test is diagnostic only when it is positive. So Fincham's test is actually used to diagnose only cataract. Okay. Glaucoma is a diagnosis of exclusion. Because cataract is not there, because halos are not breaking, that is why it will be glaucoma. So Fincham's test is diagnosing only cataract. Okay, I hope you understand the symptoms, everybody, and you understand the differential diagnosis of halos around light. Moving on to the signs of angle closure glaucoma now. Everybody try and understand that the signs will be acute. Acute presentation you will be able to see in the anterior part of the eye also. But first of all, you will measure the IOP. In these cases, the IOP is usually found to be greater than 40 mmHg. The IOP is very high. And due to this high IOP, the patient experiences severe pain in eye. The pain is so severe that the patient will come like this, holding the eye, mar gaya. You will know as soon as the patient walks in that the patient is a case of glaucoma, acute attack, because the pain is severe. The patient is saying, take my eyeball out or relieve my pain, but I can't bear this pain anymore. Why is this pain there? Try to imagine you want to go to the bathroom, you want to urinate, but you can't due to some reason. Your bladder is full of urine now, it is putting pressure. What do you start to feel, everybody? You start to feel pain in the lower abdomen because the bladder cannot stretch anymore. Simply now think about the eye. The eye has so much pressure, eye cannot stretch at all. So eye is not able to tolerate this pressure. Everything is getting stretched out. It cannot, and that is why it is giving rise to severe pain in the eye. Now, for examination of IOP, you will do digital tonometry. When I say you, I means you. On digital tonometry, as already explained to you, there will be a rock hard eye. Then guys, if you do the torchlight test, this has already been explained, everybody. Due to the shallow anterior chamber, everybody, you will see the eclipse sign. Yes, due to shallow anterior chamber. Now, when you look at the pupil, everybody, pupil is characteristically vertically oval, mid-dilated, and fixed. These are the three words we use to describe the pupil in case of angle closure. Again, please remember, I am not saying glaucoma pupil is vertically oval. I am saying angle closure glaucoma, the vertically oval pupil is seen. Open angle glaucoma, the pupil is always normal. Okay, everybody, vertically oval, mid-dilated, as has already been explained, and fixed. Why fixed? I will explain. Let's see this photograph next, everybody. Let's say this photograph comes in your exam. What do you see, everybody? First of all, you see redness. Okay, start thinking about the causes of redness. Now see the pupil, everybody. The pupil is mid-dilated. Yes, that's the clue, everybody. Mid-dilated pupil. Redness can occur in conjunctivitis, but conjunctivitis will not affect the pupil. Redness can also occur in uveitis, but in uveitis, everybody, the pupil is miost. Okay, so please remember redness. Redness occurs in conjunctivitis. Normal pupil. Redness occurs in uveitis. Meiosis. Then if it is a mid-dilated pupil, then the answer is angle closure glaucoma. Okay? So basically 3 differential diagnoses of a red eye can be answered through pupil very easily, apart from the other accompanying features which should already be mentioned in the question for all of you. Okay guys? Now after the pupillary examination, let's see what will be visible on a slit lamp. So on a slit lamp examination, the first thing that I note is edematous cornea. Or I can say a hazy looking cornea. Why? Why an edematous cornea or why a hazy cornea? Everybody, I hope you remember the lecture of the basic anatomy. Corneal transparency is maintained by tight junctions between endothelial cells. But now because my IOP is greater than 40, such a high pressure will break through these junctions, everybody. And thus the aqueous will be able to enter my cornea. When the aqueous enters my cornea will become edematous. And due to the edema, my cornea will appear hazy. Now because my cornea is hazy, the patient will complain of what, everybody? Blurring of vision. Yes? So there was no blurring or loss of vision in open angle glaucoma because actually the loss of vision is not occurring due to the optic nerve damage. It is occurring due to the blurring of or haziness of cornea. Edematous cornea is what gives rise to halos around light. Why guys? Just think of a rainbow. Why is a rainbow seen? A rainbow is seen because of water droplets in the air. Water droplets act like prism. And when light falls on a water droplet, it splits into 7 colors and you can see a beautiful rainbow. Imagine the same thing in your cornea. Now your cornea has water droplets. Light is falling onto the cornea, splitting into circles of colors and you are able to see colored halos around lights. So I will say edematous cornea gives rise to halos around light due to prismatic effect. Okay? Due to the prismatic dispersion of light. Am I clear to everybody? Now. Secondly, what will I be able to see on a slit lamp is iris atrophy. Due to the pressure, muscles undergo atrophy. Iris contains muscles. Due to that, the iris will start to undergo atrophy. Thirdly, I will be able to see posterior synechia. I hope you are not confused. In the mechanism, we said peripheral anterior synechia, but here we are saying posterior synechia. What were anterior synechia? Adhesion between iris and cornea. But when I say posterior synechia, it will mean between iris and lens. So if I define posterior synechia, I say adhesion between pupillary margin and lens. So why are posterior synechia forming? Everybody, what was the starting point of the mechanism if you remember? The starting point of our mechanism was relative pupillary block. Relative pupillary block meant apposition between pupillary margin and lens. They were touching each other, you did not remove the touch. So along with the formation of anterior synechia in the periphery, everybody, look at my elbows. This point, my finger, pupillary margin is forming an adhesion with the lens. So there are both the synechia actually seen. So there are both the synechia actually seen in case of angle closure glaucoma. If I draw the diagram, it will be like this. In the center, the pupillary margin is forming the posterior synechia. In the periphery, the iris is forming the anterior synechia, or I can say peripheral anterior synechia. So both types of synechia are seen in angle closure glaucoma. Now if you understand, because posterior synechia are formed, because the pupillary margin is in adhesion with the lens, pupil chipka hua hai. If the pupil is in adhesion, everybody, will it be able to dilate? Will it be able to constrict? No. That is why we said that the pupil will be what, everybody? Fixed due to posterior synechia. I hope you understand this simple fact. Yes? Now, next sign, everybody. Number 4. On examination of slit lamp, you will also be able to see a cataract known as glaucoma flecken. Glaucoma flecken. Fleck-shaped deposits in a case of glaucoma, cataract, glaucoma flecken. They are anterior capsular opacities which form due to lens epithelial ischemia and necrosis. Okay, everybody? So because the lens is also getting involved, there is epithelial ischemia or necrosis leading to the formation of opacities known as cataract, glaucoma, flecken. Right? So that's all about the important signs, everybody, of a case of acute angle closure glaucoma. I hope we are clear about this. Now that we are through with the mechanism, the symptom, the stages, the signs, everything, what we are left with is the treatment. So as soon as we talk about the treatment of angle closure glaucoma, everybody, the word that comes into my mind is that it is an acute condition. Acute condition means I can say it is one of those rare conditions which I can call as an ocular emergency. What is the emergency? The emergency is the very high pressure above 40, as we said, almost always as 50 or 80. Yes. So what is needed, everybody, in acute exacerbations? First of all, the first need is everybody to reduce the IOP. Reduce the intraocular pressure. Now, everybody, how do we reduce the intraocular pressure? What is the fastest way, everybody? Yes. Yes, everybody. Yes, we know this. Yes, we know this. IV mannitol. We have to give intravenous mannitol, everybody. 500 ml of 20% solution. The dosage is roughly 1 to 2 gram per kg of body weight, and this has to be infused over 30 minutes. Okay? If you don't have intravenous mannitol, everybody, let's say you don't have an intravenous mannitol, then you can opt for tablet acetazolamide 500 milligram. That is the start dose that you have to give, everybody. Okay? Now, after you have been able to reduce the IOP, everybody, what is the second thing that you want to do? You want to constrict the pupil. Pilocarpine eye drops 2% to 4%. That is the concentration of pilocarpine eye drops that we need to give everybody. Now the question comes, pilocarpine we all know is a meiotic agent. It will constrict my pupil. Okay. But why do I want to constrict my pupil, everybody? Yes, I want to constrict my pupil because it pulls the iris. Yes. See, when we are contracting, it is pulling on the iris, and in effect, it is opening the angle of anterior chamber. I hope you understand what I am trying to say here. Everybody, this is my angle. My pupil is mid-dilated in angle closure glaucoma. That means some part of my iris is bunched up in the periphery. Yes? So when I constrict the pupil, my iris becomes taut, everybody. When my iris becomes taut, a little part of my angle in the periphery will open out, allowing the aqueous to flow, breaking, everybody, the acute exacerbation. I hope we are clear about this. Yes? Now comes the question in my mind, what is the drug of choice for angle closure glaucoma? Yes, that is a question which we often come across. We are often asked. So we have two candidates. The first candidate is intravenous mannitol. The second candidate is pilocarpine. Okay. So as I've explained to you just now, both are required, one after the other.
But still, everybody, if an MCQ is asked, if a question is asked, so the drug of choice for angle closure glaucoma is pilocarpine, but the drug of choice in acute exacerbation, or I can say in acute cases, is intravenous mannitol. Okay, though these questions should not be asked, both the drugs need to be given. First of all, we need to reduce the IOP, then we need to be able to constrict the pupil. But if at all asked, this is how you answer them. Even though in these two questions I have said drug of choice, everybody, but can we keep be giving these two drugs throughout the year, everybody? Yes. IV mannitol, can you keep on giving? The patient will have to urinate after every 20 minutes. Can you keep the pupil constricted, everybody? The patient will not be able to see at night. At night, the pupil needs to dilate. So even though they are drugs of choice, they're basically temporary management. So at last, we have to have a treatment of choice. So we say after IOP control and cornea is clear. If you remember the science, everybody, we had said that the cornea will be hazy due to the high pressure, everybody. We need to move on to the treatment of choice. What is the treatment of choice? If you can see the photograph, if you know, it's all right. Otherwise, I'm explaining it to you. The treatment of choice is laser iridotomy. If you remember, everybody, the basics, everybody, that I taught, open angle glaucoma, angle closure glaucoma, we had discussed there. We have been discussing for the past 20 minutes that angle closure glaucoma occurs due to problems in iris. So the treatment has to be in iris. Yes, the treatment has to be in iris. What is the treatment? Laser iridotomy. Iridotomy means hole in iris. So we are creating a hole in iris. Why are we creating this hole in iris, everybody? We know that the pupil was blocked. Then due to the pupillary blockage, the aqueous was not able to flow from posterior chamber to anterior chamber. We know that pupil is a hole, everybody. We are saying the natural hole is blocked. So let's do a laser. Let us create another hole. Let's say this is another hole I have created here, everybody, between my thumb and my finger. If this natural hole was blocked, now this new hole, what will this do? This will allow the aqueous to flow from posterior chamber to anterior chamber. That is what the problem is. That is what I have said, everybody. The problem is of inflow. The problem is not of outflow. If the inflow is managed, everybody, it will equalize the pressure in PC and AC, and all the problem will be solved. So we need to create a hole in the iris. So creating a hole in the iris is known as iridotomy, and it is done between 11 o'clock to 1 o'clock. Now I hope that you don't think that this is the time of the day, 11 o'clock to 1 o'clock. We are not talking about 11 a.m. to 1 p.m. I hope you know this. We are talking about the position of the hole, everybody. Okay? Let us see, everybody. If we look at this image, let's say this is my 12 o'clock, everybody. So somewhere this is my 11 o'clock, this is my 1 o'clock. So we are saying the hole that we should create should be somewhere in this area, 11 o'clock to 1 o'clock. The question comes, why, everybody? Because normally, here see, to click the photograph, we have lifted the upper eyelid up. But normally we know that the upper part of the cornea is covered by iris. So even though we have created a hole, this will not be a hole through which light be able to go inside. Had we created a hole, everybody, at 6 o'clock, problem would still have been solved, everybody. Aqueous would be able to flow from PC to AC, but it may result in diplopia. Why? Because now there will be two light rays going in, everybody. One light ray will be going through the normal pupil and one light ray would be going through here, everybody. So the patient may end up having two images at the retina. That is why it is preferred to create a hole in iris between 11 o'clock to 1 o'clock. Again, I am saying it is preferred. It is not mandatory. It is preferred to create a hole between 11 o'clock to 1 o'clock. I hope absolutely. I hope it is understood, everybody. If it is understood, my last question is laser, everybody. Again, which laser will be used? We are creating a hole. Remember lens. laser posterior capsulotomy, hole in the posterior capsule. So we are creating a hole, we are creating a break, everybody. We are using which laser? ND YAG laser. Okay, everybody, no confusion about this, everybody. And that's all about our topic, everybody, the treatment of angle closure glaucoma. I hope you have been able to understand the basic fact that I've been trying to tell you in this video, everybody, that they are two different conditions, open angle and angle closure, everybody. Open angle glaucoma, problem in trabecular meshwork is there, everybody. Treatment in trabecular meshwork is there. We are trying to increase the outflow somehow, everybody. It is a chronic disease. There are no acute signs and symptoms. Angle closure glaucoma is entirely different. The main problem is the acute exacerbation. The pathology says there is some problem in the iris, and that is why the treatment is involved all over the iris part, everybody. I hope we are pretty clear. I hope moving forwards, we will remember that glaucoma is not one condition. Glaucoma is two different conditions. One left, one right. Absolutely different. Yes or no, everybody? The only common word that you will find is headache. Any other word you will not be able to find common between two types of glaucoma.